For the third and final part of the image reconstruction course we have this year, we have Dr. Lifang Yu from the Mayo Clinic. He's an assistant professor there, and he's going to sort of tie it all together. On Monday, we learned the basics of filtered back projection. On Tuesday, we learned the basics of iterative reconstruction. And Dr. Yu is going to talk about how do you optimize your acquisition and your reconstruction to get the quality and the characteristics in your images that you desire. So without further ado, Dr. Yu, if you'd like to get started.
Thank you very much, Dr. Jones, for the introduction and the invitation. Very glad to be here. And good afternoon, everybody. This afternoon, I'm going to talk about the optimization of the image acquisition and reconstruction in multi-slide CT. So Dr. Sirensen did a very nice summary of the analytical reconstruction method, and Dr. Jeff Fessler did a nice summary of the iterative reconstruction. And as a third presentation in this educational session, I'm going to focus more on the practical part of the image reconstruction. So here is the main learning objectives. First, to understand the clinical implementations of image reconstruction algorithms on multi-slide CT scanner. Understand how CT acquisition parameters affect image reconstruction and image quality, and also how reconstruction parameters affect the image quality. So first, clinical implementations. After the invention of the helical scanning technology, it became widely recognized that the wider detector collimation can provide faster scanning speed, can achieve isotropic spatial resolution, and can better utilize the tube power. So all the manufacturers, they have been pushing very hard to increase the number of detector rows. And from 1998, it only took several years for the number of detector rows increase from 4 all the way to currently the most number of detector rows now is Aquilian 1 through 20 with a longitudinal coverage up to 16 centimeter. And it seems like now this slice race already stopped. Maybe the reason may be because the state-of-the-art CT scanners now the scanning speed and the image quality already been sufficient for most of the the scanning speed already sufficient for most of the clinical applications. And and now the direction of the CT technology now is more toward to improve the image quality and to reduce the radiation dose. And image reconstruction play a very important role in these directions. So when the number of detector rows increase, one major issue in terms of image reconstruction is the cone beam effect, especially when the number of detector rows increase from 16 to 64. The cone angle increases from less than 2 degrees to more than 4 degrees. The reconstruction method, assuming a fan beam geometry or a very narrow cone beam, a very narrow cone angle, does not work anymore. And here shows one example back to 2003. Here's a Teflon rod placed in a water tank, and scanned on a 16-slice scanner, and both in the center position and off-center position. And here shows the images reconstructed for the center location. To the left is a standard 2D FVP method, and to the right is the AMPR method that takes into account the small cone angle effect. And here shows the images for off-center location. You can see the significant improvement of the cone beam artifact by using the AMPR method that takes into account the cone angle effect. Here shows another example. This is a digital head phantom. It has a very challenging low contrast object and very complicated high contrast object. And this phantom has been used for testing the accuracy of the cone beam reconstruction method. And this simulation was for a 256 slice scanner. And these images were reconstructed by using a reasonably accurate cone beam method. It's called the wedge method. But still, you can see a lot of artifact in these images. And to the right is a more advanced cone beam reconstruction method. Not perfect, but still you can see it to reduce the artifact a lot. And over the last 2 decades, there have been a lot of reconstruction methods developed. The main purpose is to improve the accuracy of the reconstruction for helical multi-slice CT with wider collimation. And among them, some of them, most of them actually are approximate method. And among them, there are some exact methods, such as Kasvich's method and the back projection filtration method developed by Zhou and Pan, which can utilize the minimum data to do the exact reconstruction. And although those are some of the exact methods are available, all current scanners they still use approximate method. The main reason, one of the reasons may be because all those approximate method on the clinical scanner are still assumed to have a good balance between the computational efficiency, the accuracy, and the dose efficiency. Another important reason maybe because the emerging iterative reconstruction, which promise a better image quality and a better dose efficiency. So it receives more attention than those exact 3D reconstruction method. This slide just summarizes some of the reconstruction method developed by the vendor or implemented on their scanners. Most of them are based upon 3D filter back projection method. They are all approximate, which means they still, to a more or less extent, they still suffer from the cone angle effect. There are some slight variations among different implementations, mainly on the weighting scheme. Since this presentation will be more focused on the practical optimization of the acquisition parameters, so I will not go into detail to explain those reconstruction methods. So for typical CT users, the reconstruction method available on the scanner, basically it's a black box. We don't have any control on what kind of reconstruction method used on the scanner. What the users can control is several acquisition parameters or image reconstruction parameters available through the user interface. Here shows one example of the user interface from the Philips scanner, and here's the user interface from the Siemens scanner. And there are a lot of different parameters on the data acquisition part and the image reconstruction part. So this presentation will be focused on discussing how those parameters affect the image quality. So now let's move on to the how the acquisition parameters affect the image quality. Here I list a lot of acquisition parameters that we have some control over, including the scan mode, the rotation time, beam filter, beam collimation, detector configuration, helical pitch, tube potential, tube current, mass, effective mass, and automatic exposure control. These are the some more frequently used scanning mode: the axial mode, ceiling mode, helical mode, shuttle, or 4D spiral mode. The axial mode now is much less frequently used than the helical mode, but it still finds some niches in some of the clinical applications, such as the prospectively gated ECG gated sequential scan for cardiac scan, because of its it is more dose efficient than the retrospectively gated helical scan. And also for some of the head scan, because the image quality is demonstrated to be better than the helical scan in some of the head exams. The shuttle or 4D spiral mode, this is a relatively new scanning mode. So basically for the axial shuttle mode, it's an axial scan actually, just to go back and forth. And for the helical 4D spiral, it also go back and forth. And the helical pitch will increase and then decrease and then increase again. So it's this mode is primarily for the perfusion scan. The main purpose is to increase the volume coverage range. And the pitch is an important parameter in the helical scan, which is defined as the table translation per rotation divided by the detector collimation. When the pitch is less than 1, there is some overlap. When the pitch is bigger than 1, there's some gap. And here shows a simple and graphic demonstration of the how the data is utilized in the image reconstruction for different pitch value. So you can see that when the pitch is less than 1, as shown here as the purple shadow region, those are the redundant data because of the overlap of the during the scan. And for the image reconstruction, we have to utilize those redundant data so that the radiation dose is not wasted. And when the helical pitch is greater than 1, there is some gap in between. So some type of interpolation has to be used to fill those gaps, and this is the origination of some of the helical artifact. So pitch has a very important impact on the image quality, and for higher pitch, you can get a higher scanning speed. And this is actually beneficial for some of the non-cardiac exams. A higher pitch scan actually is beneficial for improving the temporal resolution, because for each image, in order to reconstruct this image with a higher pitch, a less angular coverage range is used. So that corresponding to a better temporal resolution. And sometimes this is useful for some of the, especially in the chest exams. So be careful when designing chest scanning protocols. You don't want the pitch to be too slow. There's some downside of higher pitch. For the fixed rotation time and the maximum tube current output, the dose capacity is lower for higher pitch. So for scanning a obese patient, the higher pitch is not desired. That could result in insufficient dose and then could result in severe photon starvation artifact. A higher pitch also can cause more severe helical artifact. And also if combining the higher pitch with a wider collimation, more severe cone beam artifact can be seen. Detector configuration. Here shows examples of detector configurations for GE scanner. For the Lightspeed VCT and HD750, the detector configuration is 64 by 0.625 with a longitudinal coverage of 4 centimeter. And for Siemens scanner, the AS Plus or the flash scanner, they have similar detector configurations, 64 by 0.6 with a longitudinal coverage almost 4 centimeter. But with the flying focal spot, along the Z direction, the 64 detector row, the 128 slices can be simultaneously acquired, so they code the AS Plus and the Flash still 128 slice scanners. The main benefit of the Z flying focal spot is to increase the sampling density along the Z direction. The effect is to improve some of the aliasing artifact. I show here to the left, there's some streaking artifact originated from this dense bony structure. It's caused by the aliasing. And with the Z flying focal spot, you can see a much improved along this region. One important consideration for the detector configuration is the electronic noise. So for thinner detector element, it tends to have a higher electronic noise. So when the the scanning technique is low, it tends to generate a severe photon starvation artifact. As shown in this example, this phantom is relatively big. It's about 40 centimeter in the lateral width. And we scan with a relatively lower technique. Exactly the same volume CTDI and the same physical detector collimation, but one with 128 by 0.6 millimeter. Here, there's a flying focal spot here, and the other one with 32 by 1.2 millimeter. So you can see the big difference of the image quality. So this has an important implication on when you design the scanning protocols for a obese patient. A thicker detector element can allow a lower radiation dose and can improve the image quality. Of course, you lost the possibility to reconstruct thinner slide thickness, but for many of the routine exams, this is not relevant. You don't need that thin slide thickness. So wider detector collimation is routinely used to achieve a faster scan speed and better use of tube power. However, it tends to generate a more severe artifact if it is not well corrected, such as the helical and cone beam artifact. This is particularly for the high contrast object at high pitch. And for some of the applications, narrow collimation is better. For example, for the head CT on GE VCT scanner, the 32 by 0.625 millimeter is often a better choice than the 64 by 0.625 millimeter. And if there is no time concern, then use a slower pitch for the wider collimation. Here shows an example of cone beam artifact in wider detector collimation. You can see, this is it's called a clock phantom. It has a lot of sphere structures along the z direction, so it's a good test for the cone beam artifact. You can see that with the increase of the helical pitch, the cone beam artifact become more and more severe. For comparison, we acquire the image with a narrower collimation with the same volume CTDI. With this narrow collimation, even for a higher pitch, the cone beam artifact is not as severe as using the wider collimation. X-ray beam Bow-tie filter. For the patient usually is an oval shape, so the attenuation is higher in the middle and lower in the peripheral region. The design of the Bow-tie filter is to make it thinner in the center and thicker in the peripheral region so that the patient dose can be reduced, especially the skin dose. Some manufacturers provide several options of the Bow-tie for different patient size, small, medium, large. It is important to match the Bow-tie filter for the to the patient size. If using a small Bow-tie for a large patient size, then you can think about in the peripheral region you don't get sufficient flux, so you might end up with inferior image quality, especially in the peripheral region. And if you use a large Bow-tie for a small size patient, then the benefit of dose reduction using the Bow-tie filter is not there, because there is no reduction of the dose to the patient peripheral region. MAS, effective mass per slice, depend upon the CT manufacturer. They name it differently how to prescribe the tube current. This is probably the most frequently manipulated scanning parameter in daily CT practice. The effective mass is defined as the mass divided by the pitch, and it is proportional to the radiation output. For those scanners need to prescribe the MA, note that it cannot be related to the volume CTDI without knowing the pitch. The impact of the mass on the image quality is pretty clear. The higher the mass, the lower the noise, and the better the low contrast detectability. And here shows one clinical example, exactly the same image, but with different level of effective mass. The lower level of effective mass was a simulation by inserting the noise to the original projection data on the original data acquisition, and you can appreciate the change of the all those lesions with the different dose level. This method, noise insertion method, is a very useful tool for optimizing the CT scanning protocols. Can simulate several different dose levels, and then the radiologist can look at the image and decide which is the lowest acceptable dose level. The mass, the relation between the mass and the noise is very simple, but should be noted that they are different in cardiac exams and non-cardiac exams. For the non-cardiac exams, the image noise is directly related to the effective mass, so the pitch is here. This is because when the pitch is less than 1, all the redundant data is used, so the image noise is related to the pitch. And in cardiac exams, because we want to improve the temporal resolution, so during the reconstruction, even the pitch is very, very low, usually it's like 0.2 to 0.3. There's a lot of redundant data. However, to improve the temporal resolution, only the data in one single rotation and a half scan range is utilized. So this is why in cardiac exams, imaging noise is directly related to the mass. It is independent of pitch. For bigger size patient, if the mass is not high enough, you may see this type of artifact called photon starvation artifact, some rings in the center, and even with a very smooth reconstruction kernel. And Siemens provided this special kernel that can be used to compensate for some of the artifact associated with photon starvation. And for some body region, especially the shoulder region, because the attenuation level is very non-uniform, across the lateral region, the attenuation level is very high, and the AP direction is low. So this usually leads to severe streaking artifact. And some manufacturers, they implement a so-called adaptive filter, which applies a smoother filter along the AP direction for those high attenuated projection data, and a sharper filter in the less attenuated data. Then the streaking artifact can be reduced. So talking about the mass, one of the most important techniques for reducing radiation dose or improving the image quality is the automatic exposure control. The patient size varies, and for the same patient, X-ray attenuation also varies over different body region and across different projection angles. Because image noise is primarily determined by the noisiest projections. So for constant tube current, the more photons for the thinner body part actually is unnecessary. So the goal of automatic tube current modulation is to dynamically adjust the tube current according to the attenuation level. So basically use more tube current on the higher attenuation and lower tube current on lower attenuation. The basic principle of automatic tube current modulation was nicely described in the original publication by Guy's calendar, et al. And there is a very important parameter in this formula, the X, which is the modulation strength. This figure demonstrates how the modulation strength affects the tube current modulation. The horizontal axis is the attenuation relative to a reference attenuation level. You can think about that as a standard size patient as a reference attenuation level. And the vertical axis is the tube current relative to a reference tube current level. And these 5 curves show how the tube current changes with the change of attenuation level for different modulation strength. When the modulation strength is 0, the tube current keep constant, and that's without any tube current modulation. When the modulation strength equals 1, that's a strategy to keep exactly the same image noise for different attenuation level. Actually, in diagnostic CT, this strategy is unnecessary. This is because when the patient size is bigger than a standard size patient, their structure is bigger and there is an inherent higher contrast. So the noise can be allowed to be higher than what is in a standard size patient. And for smaller size patient, because the structure is smaller and the inherent contrast is less. So you need lower noise to achieve the same diagnostic performance. That's why this constant noise strategy of automatic tube current modulation is not appropriate. And more reasonable modulation strength is between 0 and 1. It should be noted that some manufacturers they apply different modulation strength, and this fact should be realized so that you can implement appropriately in the practice. So here shows how the automatic tube current modulation works in practice. I use Siemens Kerdos as example. First, take a topogram, and then the scanner will calculate the attenuation level both along the AP direction and the lateral direction for each slice location. And then based upon the modulation strength, the reference mass provided by the user, which prescribe a certain desired image quality, the scanner will calculate the optimal MA along the AP direction and lateral direction for each slice location. And then during the scan, the software will utilize the information provided by the prior 180-degree acquisition to fine-tune the tube current modulation. This outcome of automatic tube current modulation can achieve uniform image quality across different body regions. And another benefit of automatic tube current modulation is the reduction of the streaking artifact, because it automatically increases the mass when the attenuation level is high in this lateral direction, so the streaking artifact is improved. And here shows some different versions of the AEC from different vendors. The detail of those implementations is beyond the scope of this presentation. If you're interested, you can do more detailed investigation on those implementations. Another important acquisition parameter is the tube potential. Here shows examples of spectrum of those of 4 tube potential on one of the 120H slices. The lower kV, the 80 kV, for the same mass, it has a much less radiation output. 120 kV is the most frequently used kV, but recently the lower kV receive a lot of attention to reduce the radiation dose or improve the image quality, especially in some clinical journals. And the main benefit of the lower kV is the improved iron-down contrast, as seen in this figure. And the benefit of the lower kV is also demonstrated in this clinical example. This patient was scanned on with a 120 kV and a 100 kV in a 4-month interval, and you can see the better enhancement of this mirror stratification, despite that the 25% dose reduction at 100 kV. However, lower kV has a main limitation. It tends to increase the noise, especially for a bigger size patient. This can be clearly demonstrated in this figure. 3 size phantoms scanned at different kVs, and for each kV, for each size of phantom, the volume CTDI is fixed. You can see that for smaller size phantom, the noise doesn't change much across different kVs. But for large size phantom, the noise increases dramatically for lower kV. So from these examples, you can see that there is a trade-off between the contrast and the noise when selecting the KV when using the lower KV. And to select, here's another example showing that the increased noise at lower KV. So there is a compromise, and to select the optimal KV, so basically it's the optimal KV is the KV that uses the minimum radiation dose to achieve the desired image quality. And this optimal KV is dependent on both the patient size and the diagnostic task. And a general strategy was proposed for selecting the optimal KV, which uses a novel quality index, iron-dye contrast to noise ratio with a noise constraint. And this noise constraint can be associated with different diagnostic tasks. And by matching this quality index, the relative dose at each KV can be calculated, and then the most dose-efficient KV can be selected. And here shows one example of optimal KV for abdominal CT. Here the modulation strength is related to the noise constraint, which can be associated with different diagnostic tasks. For non-contrast study, usually the higher KV is indicated. For contrast study, especially for CT angiogram, because of the high contrast vascular structure, the lower KV is usually has the best dose efficiency for the smaller size patient. And a similar strategy has been implemented by one of the manufacturers. It's called Care KV, and some preliminary clinical studies have demonstrated about 20 to 40% dose reduction. So next, let's move on to the reconstruction parameters. Slide thickness, reconstruction kernel, reconstruction FOV, 3D reformat, and iterative reconstruction or noise reduction options. The slide thickness is the nominal width of the image along the Z direction, which can be characterized as a slide sensitivity profile, showing this example. This slide shows the how the slide thickness is related to the noise and radiation dose. For a 5 millimeter slide thickness, assuming the noise is 1 and the mass is 1, when the slide thickness is reduced to 2.5, the noise increased to square root of 2 if keeping everything the same. And in order to match the noise in the 5 millimeter slide thickness, the mass needs to be doubled. And for 1.25 millimeter, the mass needs to be 4 times in order to match the noise level in the 5 millimeter slide thickness. So the thinner slide thickness has a better Z resolution. However, it increases the image noise and requires more radiation dose if you want to match the noise in the thicker slide thickness. The slide thickness has a big impact on the partial volume effect along the Z direction. Here shows some images from the ACR slide thickness pattern reconstructed with different slide thickness. You can see with the increase of the slide thickness, 10 millimeter slide thickness, more line ramps can be seen in one image. And but the intensity of each line dropped a lot. This is because of the partial volume averaging along the Z direction. And with the decrease of the slide thickness, fewer lines can be seen in the one image, and each line appears to be much brighter, and because of the less volume averaging along the Z direction. Here shows one clinical example. This is a image with a 10 millimeter slide thickness. Can anybody see a small lesion in this image? Yeah, it's right here. It's very subtle lesion. This is mainly because of a much thicker slide thickness, and the volume averaging make this lesion appears to be very low contrast. And then if we reduce the slide thickness to 5 millimeter, it's a little bit better, but still very subtle. And reduce to 2 millimeter. Now the lesion pops up immediately, and 1 millimeter, 0.6 millimeter. So here the contrast actually doesn't change much, but at the same time the noise increases a lot. So you can see from this example, there's a trade-off between the slide thickness and the noise. So we want the slide thickness to be thin enough so that we don't miss any lesion. However, we don't want the noise to be too high to degrade the detectability of the lesion. Reconstruction kernel. Some manufacturers call reconstruction kernel as a filter or algorithm. It has a significant impact on the spatial frequency and noise characteristics of image. A smooth kernel reduces high spatial frequency information and image noise. A sharper kernel increases high spatial frequency information and image noise. And here shows the impact of reconstruction kernel on the in-plane spatial resolution. A sharper kernel can resolve more line pair per centimeter. A smoother kernel can resolve less line pair per centimeter. And the in-plane spatial resolution is better quantified with the modulation transfer function. And here shows one examples of modulation transfer function of some smooth kernels from the Siemens scanner. You can see here is an overshoot at a lower spatial frequency part. This is because of the edge enhancement implemented together with those smooth kernel. And the impact of the reconstruction kernel on the low contrast resolution is pretty complicated. It not only depends upon the noise level, it also relies on the noise spatial correlation and also the spatial resolution. So here I show some images. Let's go back and forth. Here's the image with a soft kernel and the standard kernel, the detail, the bone. Yeah, I can go back again. So the soft, standard, detail, and bone. You can see that not necessarily the smoother the kernel, the better the low contrast spatial resolution. Also not the other way around, with the sharper the kernel, the better the low contrast spatial resolution. For this case, actually, the standard kernel has the best low contrast spatial resolution. And here shows some different image appearance reconstructed with different GE reconstruction. They call it algorithm. The soft, standard, detail, long, bone, edge, and bone plus. Here's some considerations on the GE reconstruction algorithms. The long and bone plus alter the CT number values. For high res long, you use bone kernel. The standard is the most frequently used algorithm. The soft is to recover a really graining exam, and use the full recon for getting the slice width you want. And for the plus mode can help you to smooth the noisy image or reduce some artifact, but the slice width of the plus mode is about 20% higher than the nominal slice width. I show some Siemens reconstruction kernel, and this is a summary of the Siemens body kernels and the head kernel. There are a lot of kernels on Siemens scanner, so in order to better utilize them, you have to understand the detail what their feature is. This is just an example of UHR kernel for inner ear structure, the U30, 40, 70, 75, 80, 90. Okay. Reconstruction FOV. Very simple. The higher the reconstruction FOV, the larger the pixel size, and the smaller reconstruction FOV, the smaller pixel size. And the pixel size should not be confused with the system spatial resolution. The system spatial resolution is determined by the size of the focal spot, the system geometry, the detector size, and also the reconstruction kernel. But the pixel size is just determined by the FOV size, the reconstruction FOV size. You can randomly select it. So they are not the same thing, but this actually occurred a lot in the radiology world. Many people kind of confused about those things. And they're not the same thing, but the pixel size should be small enough in order not to limit the display of system resolution. So for 512 by 512 matrix, here shows some the pixel size resolution in terms of 9 pair per centimeter. And for some with some reconstruction kernel, the 10% MTF, here's some 9 pair numbers. So the pixel size should be small enough. If you use too big pixel size, that might not achieve it might limit the display of the achievable system spatial resolution. So I also would like to mention the 3D reformat. Now it's more frequently used in the CT exams. Some vendors, they provide direct reformat from the raw data, which is a very nice feature. And some other manufacturers, they use 3D reformat directly from the axial recon. And here compares the reformat from a 1 millimeter axial reconstruction and a 2 millimeter axial reconstruction. You can see that the 1 millimeter axial reconstruction provides a much better quality for the 3D reformat. So all the 3D reformat should be based upon thin axial reconstruction. So finally, I would like to discuss with you about the iterative reconstruction. Dr. Fester already provided a very nice summary of the iterative reconstruction. Basically, the benefit of the iterative reconstruction over the analytical reconstruction is the accurate physical model, the appropriate statistic model, and also some other benefits, including the non-negativity object constraint, the flexibility to handle all non-standard scanning configurations, and the potential to reconstruct images from sparse or incomplete data. And all the vendors now, they provide some type of iterative reconstruction or noise reduction method. Like GE has the Acer, the MBIR, Philips iDose, Siemens Iris, and Sapphire, Toshiba AIDR3. And some of them, they are real full iterative reconstruction, go back and forth between the projection, the raw data, and the image domain, like the MBIR. And some of them are hybrid method. And mainly do the iterative denoising in the image space, but it's aided by some properties in the centigram domain, like the Siemens Sapphire. And some of them are just purely denoising method, either in the image domain or in the raw data domain. Iterative reconstruction has a great potential to improve the image quality, as shown in this example. However, it is not without concern. These images are from Dr. Amy Hara's original paper in AJR about the Acer reconstruction. You can see that on the left is the standard FBP, the right is the Acer reconstruction. Although the noise level is dropped, but the noise texture changes dramatically. Here the image looks very pixelized, or you can call it blotchy looking. And the influence of this noise texture on the diagnostic performance right now is still unclear. And to quantify the dose reduction of the iterative recon, we have to take a look of the low contrast detectability. And here also these two images are from that paper. I apologize, this directly from that PDF may not be that clear, but on the left is FBP reconstruction with 25 milligray, and on the right is the Acer reconstruction with half of the dose. In order to claim a 50% dose reduction, those low contrast resolution should be matched, but from my point of view, they are not even comparable. So when you claim the dose reduction, the low contrast detectability has to be evaluated very carefully, not just based upon the high contrast resolution. So here's a summary of some special considerations on iterative reconstruction. Based upon some preliminary clinical study on the iterative reconstruction, the potential for dose reduction may be 20% to 50%, and it is task specific. For some high contrast task, it allows more dose reduction, but for low contrast task, it allows less dose reduction or even no dose reduction. And as I said before, the noise texture could change dramatically from the iterative reconstruction. And either this could sacrifice the diagnostic performance, or the radiologist need to get used to the change of the noise texture. But the influence of the noise texture change on diagnostic performance now is still not that clear. As mentioned in yesterday, Dr. Fessler's talk, the nonlinear regularization term also leads to a nonlinear noise resolution trade-off. So spatial resolution is highly dependent on the contrast level. And if you do evaluation, you may observe that the noise can be reduced a lot, but the high contrast spatial resolution, if you measure the MTF, almost don't change at all. And this cannot be used to say, oh, I can reduce the dose by certain amount percent. And the low contrast detectability should be the one to decide to calculate the dose reduction potential. And this need to be evaluated more carefully. And the quantitative evaluation and optimization of iterative reconstruction now is still an active research field. So, in summary, we have gone through the implementations of reconstruction algorithms on the clinical scanners, how the data acquisition and the reconstruction parameters affect the image quality. Understanding of all of this is essential to design those efficient and quality scanning protocols for various diagnostic tasks. Okay, that's all I have. I'd be happy to take some questions.
how the iterative reconstruction algorithm can help reducing the cone artifact.
In the cone beam artifact?
Yeah.
I would predict, I don't have any example, because the cone beam artifact is originated from the analytical reconstruction. It does not take into account the exact cone angle effect, and only by using exact reconstruction the cone angle effect can be removed. But iterative reconstruction can quantify this system geometry more accurately, and I can predict it can improve the cone beam artifact. Yeah, that's my guess.
Yes, in tube current modulation or KV modulation, do you know if the manufacturers changed the focal spot size? And if they do, have you looked at the effect this might have on spatial resolution?
Oh, that's a very good question. I heard that the lower KV has slightly increased the focal spot size, and has we were trying to quantify that, but it is very subtle. By measuring the MTF, I don't see a significant decrease of the spatial resolution. Other than that, I don't have further information to answer your question. In terms of noise and contrast, that's quantifiable. But in terms of the slight loss of spatial resolution, not quite sure. If the effect is very small, then when you do the reconstruction like soft tissue kernel or thicker slide thickness, then those slight degradation of the spatial resolution may not be a big effect. That's my guess. Yeah. Any other questions? Okay, if not, thank you very much. Yeah.